Hello students, it's Professor C. I'm going to talk to you about herpes and all the different herpes viruses there are. So coming over here to our PowerPoint, so we have 8 different herpes viruses in total. We're going to talk a little bit about all 8 of them today. Meet the happy herpes family, and they never move out, meaning once you acquire a herpes virus, you have it forever. It can lay in dormant in your body and reactivate later with some immunosuppression. So once you pick it up, all 8 of them establish lifelong latency. They can reactivate, especially if you are immunocompromised. There's no cures, but we do have a vaccination for one of them, and we do have a couple of antivirals that are pretty effective for the first 3. So usually when you get an infection, your body can do either one of 2 things. It can either totally kill it, or it can just contain it. And when it comes to the herpes viruses, all your body can do is just contain it. It can't totally kill it. So once you have it, it's always alive, but in a dormant state somewhere in your body. So the herpes viruses, they don't all stay dormant in the same area. There are different areas that your body will contain it at, and we're going to go over each of those. So moving in days. So once you acquire it, just know that with all 8 of them, it is a permanent lifelong infection that has reactivation periods. So we're going to start with the first 2 here, the herpes simplex 1 and herpes simplex 2. A lot of you are probably more familiar with these 2. Herpes simplex 1 is generally associated with oral cold sores. That is the virus that causes cold sore lesions, but it can also be in other areas of your body. They are 2 distinct viruses. They're very similar. They can cause painful blisters, and the first infection is always the worst, but they are distinct. They are distinct, and so how we test for them to see if the patient has herpes simplex 1 or herpes simplex 2 is, 1, we do a PCR viral swab, so we will swab a active lesion. And you can see here they're swabbing that. They're going to send it into the lab, and then the lab will be able to tell if that sore is herpes simplex 1 or herpes simplex 2, because both of them can cause oral lesions. We can do a blood test as well. Move myself over here. The blood test will tell us if you have antibodies to HSV1 or HSV2, but that's all it tells us. It just tells us that your body has created immunity to it and that the virus is somewhere in your body, but it doesn't tell us where. It doesn't tell us if it's because of an oral lesion. It doesn't tell us if it's genital. It doesn't tell us if it's somewhere else in your body. So when you have patients come in and they have an active lesion, then a lot of times we will swab the active lesion, and then we will also do a blood test. For 2 reasons. 1, we can distinguish then if it's HSV1 or HSV2, and 2, if there are no measurable antibodies, then we know it's a new infection, and we're going to talk about that. So looking at our timeline here, most patients are able to form antibodies after their initial primary exposure within 2 to 12 weeks. Most people, usually about 3 weeks, they've got measurable antibodies and adequate antibodies, but sometimes it can take up to 12 weeks to fully form immunity. So going back up here, if I have a patient that comes in and they're like, oh my gosh, I've never had a sore like this before, we swab it and it tests positive for HSV1 or HSV2, oftentimes we will do blood tests at that same time, and we can tell if it's a new infection, or if they have antibodies, we know that they've had it for more than 3 to 12 weeks. They could have had it for years, and this is their first outbreak. If they don't have antibodies and the swab tests positive, then I know it's a new infection. And just a quick review over our antibodies. These are the main 3 that I like my students to know. IgE, that's an emergency. You need to go to ER and have epinephrine. We're not talking about IgE antibodies today. IgM means you just met. They're not as accurate. You can have some false positives. We used to draw IgM and IgG antibodies quite often when we would initially test people for herpes, but because of the false positives, this has kind of fallen by the wayside. Mayo Clinic has quit doing that. We used to send, at the clinic I worked at, we used to send blood work to Mayo Clinic quite a bit, and they don't do that anymore. So, but we do IgG. And students, I want you to remember IgG means you're good to go. So if your patient has IgG antibodies, not just with herpes simplex, but with anything, that means they're good to go. They have got antibodies to that particular virus. So coming down here, so when we're talking about HSV1 and HSV2, wherever you pick up your primary infection, that's the nerve root that it's going to stay at. So for example, HSV1, we generally think of it as being dormant in the trigeminal nerve. This is very common, especially among kids that, you know, maybe have shared drinks and now, you know, they have this wonderful milkshake drink, for example, and they share it with their friends, but they've got a cold sore, and now their friends all have cold sores. So wherever they pick it up, that's where it's always going to be. Usually the initial infection will cause sores all over the oral mucosa. Sometimes it'll cause a sore throat, sometimes a low-grade fever, and sometimes this can be just mistaken for another viral illness, not necessarily a primary herpes pharyngitis. But anyway, so once that's picked up, the HSV1 or HSV2, whichever has been picked up, it lies dormant in the trigeminal nerve. So it's in one of these three branches. So if you pick it up as an oral lesion, it'll be down on, V3, right down here. And whenever you are sick or stressed or your immune system isn't up to par, your body isn't containing that herpes virus anymore, and it will come out along that nerve root as a painful, blistery rash. Students, the virus doesn't jump branches, so if it's picked up in this branch, it will always be in this branch. If it's picked up in the V1 of the top branch right up here, then it'll always be up there. And I've had patients actually have sores up there. The thought is probably they had a little sore as a small child, and then somebody with a cold sore kissed their boo-boo to make it all better, and that's where they picked up the HSV virus. And now when they're sick, stressed, or their immune system isn't up to par, that's where they have their painful blistery rash. It's wherever you picked it up at. You can also pick it up, oops, let me fix that. You can also pick it up on your finger. Back in the day, before it was commonplace to always wear gloves at the dental office or OB nurses or any number of things, sometimes our older dental hygienists and nurses will have a herpetic whitlow on their finger, so their primary infection when they first picked it up was on their finger, and so now it's along that nerve root, and whenever they are stressed or their immune system isn't up to par, that's where it breaks out. Students, sometimes with wrestling, you'll hear the term mat herpes. That can be HSV1 or HSV2, and that would be a patient or a wrestler who has no history or no antibodies to HSV1 or HSV2. They're on the mat. They become exposed to the virus from another player. Oops, let me move that. From another player, and then they end up having that rash wherever they've picked it up at with an open sore, and that's where they will forever have their HSV infection is along that nerve root. So remember, your primary source of infection is where you picked it up at. So a common misconception is that HSV1 is always a cold sore and HSV2 is always genital, and that's not the case. Actually, right now, HSV1 accounts for 30 to 50% of newly acquired HSV infections, and that's because of changing sexual practices. So you may have patients that you're taking care of, and one partner has HSV1 as a cold sore, but if their current partner has no history of HSV1, so no IgG antibodies, no protection to herpes, they can pick it up either as, from kissing, from an oral to oral contact or saliva, or they could pick it up from the genital mucosa. Now, I bring this up because in theory, if one patient has HSV1 and the other patient has HSV1 and they have had that for years and they've got both their own IgG antibodies, then they shouldn't infect each other because they both have been infected with the virus previously, and they've got their own antibodies and their own protection to it. Okay. Going back up here, remember I said that antibodies or your body's own protection doesn't start to form right away. It takes usually up to 3 weeks before you form immunity to it. So if you have patients who are new partners and one has HSV1, in theory, the partner could also pick up HSV1 from their new partner orally and also to their genital region, because if they haven't formed their 3 to 12 week antibodies yet up here, and oral sex is performed, then that body doesn't have that antibody protection, and they may pick it up in that nerve root also. So when it is picked up in the genital region, it stays in the sacral ganglia, and it will break out on one side or the other when the immune system is not up to par. So another thing to think about too, this is another example of a herpetic whitlow. If somebody has this on their finger, you know, girls, maybe we should make sure and wash our hands before we go to a public restroom. I'm just saying, because that can pick up and stay in places that we don't want it to. Move myself up here. Okay. So HSV1 used to be infected by a lot of the population, and most always was with oral lesions. And practices have changed over the years. It used to be much more commonplace to share utensils, share share drinks, and so it would spread through a community or a classroom quite easily. And now people are a lot more diligent with not sharing drinks or utensils, and so we have a lot more adult population now that doesn't have a history of HSV1 or HSV2, and that's how they can acquire it, acquire it by mouth or genitally. So over here again, the HSV1 site can be in the genital area, and we don't make those antibodies for weeks after the first exposure. So, and then this is actually HSV1 is now accounting for 30 to 60% of new HSV1 infections. Go over a couple of things here. For the most part, it is extremely difficult to pick up an HSV infection from a toilet seat. I know that's a very common myth, but it's not completely something that we can rule out. As you can see here, it can be inactive on porous surfaces for a couple of hours in ideal conditions. Most of the time it's done for in about 45 minutes. And remember too, with a toilet seat, you would have to sit on the toilet seat and have a mucosal membrane exposure directly on that, or an open sore, not just your skin, closed skin on that toilet seat. But I also want to point out glass surfaces, it can remain on there a lot easier. So something to think about again when you are seeing people share drinks or lip balm or possibly a razor or a towel. We do have antiviral medications, acyclovir, valciclovir, and famciclovir, but they only work for HSV 1, 2, and 3. And human herpes virus 3 is your varicella virus that causes chickenpox and shingles. So that is the first two. We are going to jump ahead to human herpes virus 4 and 5 and talk about the Epstein-Barr virus and cytomegalovirus. So mononucleosis, so that is known as the kissing disease. It is caused by the HHV4 Epstein-Barr virus. And when it goes, when you get over mono and it goes dormant, it actually stays in your B lymphocytes. It can also be in your throat and epithelial cells and some in your blood cells. Your patients with mono, they're going to be sick, they're going to have a headache, they're going to have a fever. A lot of times your mono patients will have occipital chain lymphadenopathy, not just anterior cervical chain adenopathy like we think of with our strep patients. I put this in here, penicillin encephalosporin rash. So a lot of times your mono patients, their throat will very much look like a strep throat. They will have swollen tonsils, they'll have exudate, they'll have a fever, they'll have swollen lymph nodes. And before strep testing was commonplace, physicians would treat just based on symptoms. And we found that people maybe have been labeled, if you are given amoxicillin or penicillin or a cephalosporin antibiotic with mono, a lot of times patients will break out with a rash, and then they were misdiagnosed or mislabeled as having a penicillin allergy when really it wasn't a penicillin allergy. It was a rash that developed because they were giving this type of antibiotic with mono. So fever, fatigue, a spleen. So your patients with mono or HHV4 virus, they can actually get an enlarged spleen. So if your patient has mono, a lot of times we will pull them out of sports for 6 weeks, because with that enlarged spleen, we don't want them to take a hit to their spleen and cause it to rupture. So this is just another graphic showing where the monocytes like to stay dormant, or Epstein-Barr cells like to stay dormant. So this is how it works when you have mono and it resolves and you get over having your initial infection with mono. It then hangs out in the B lymphocytes, and that's where it stays dormant. Okay, and we can draw IgG antibodies and see if you've ever had mono. Sometimes, though, it can periodically reactivate, and you can get mono again, and you can also shed the virus again. But you can get mono more than once because it can reactivate. Because all herpes viruses, you always have them. Your body can't kill it. All it can do is contain it. It's kind of a neat story with this. So in 1964, Dr. Epstein and Dr. Barr were studying samples from Burkitt's lymphoma tumors. This is a cancer that is found more often in Africa, and so they were studying this, and they found that this virus actually can cause cancer. And this was a huge breakthrough. This was the first time that it was found that a virus, a viral infection, can actually cause cancer. So this opened up a whole new thing of oncogenesis, and a lot of good research actually came from this. So these are the two physicians, Dr. Michael Anthony Epstein, who was a British pathologist, and Dr. Yvonne Barr, who was a virologist. I can't hardly say that. They were working together, and that's why we call Epstein-Barr virus what we do, is because of these two wonderful physicians. In addition to that, I want to talk to you about this. This is another mono case, and then a mono story, and we'll get back to our herpes lecture. If some of you might have heard of The Boy in the Bubble, this is the story of David Vetter. He was born in 1971, and he had already lost a sibling to a severe something called severe combined immunodeficiency. So basically he was born without a working immune system. His older brother had already died. They were pretty sure that David was going to be born with the same issues. So he was born by cesarean section and then basically put into a sterile environment right after that. And they kept him alive, and he was known as the Boy in the Bubble. He lived until he was 12, hoping for a cure. And so research kept going on. NASA actually made him a little spacesuit so he could go outside of his bubble. He could never touch his parents directly. He had no immune system. So anyway, later on, they found that his sister would be compatible for a bone marrow transplant. And this was going to be wonderful. This was supposed to be the cure that was going to get him out of his little bubble, and he was going to be able to live a wonderful life. What they didn't know then is that his sister had mono, and the dormant mono virus with her actually is what killed him. So because of this case, we now treat our transplant donors and recipients different. We do huge viral panels. We check them for Epstein-Barr, we check them for cytomegalovirus. And then after a transplant takes place, we actually watch them very closely for possible reactivation of the virus from the donor. And now we've got different interventions that we now know we can do. It was a hard lesson learned from David Vetter. And there's actually a movie, if you guys are interested. John Travolta actually played the part of David Vetter. The movie has a happy ending. They don't talk about in the movie how he died later from Epstein-Barr virus, but it's a movie. But it's really neat. the human herpes virus 5. This one is very similar to mono, which is why I kind of grouped them together in this portion of our lecture. It can cause very much mono-like symptoms. Its latency site is in the lymphocytes. Excuse me. It can reactivate in people who are immunocompromised, and this one is very easily spread. Saliva, urine, blood, breast milk, sexual contact. It is a highly contagious disease, and again, once you have it, then you have it forever. But the primary infection can actually make you feel pretty sick. Like I said before, similarities to mono. It can, it hangs out in the lymphocytes in the saliva. Cytomegalovirus, students, my female students, if you know somebody has cytomegalovirus and you plan on having kids later, go hang out with your friend now that has cytomegalovirus. This way you can get it now, get your primary infection over with, because you do not want to have your primary infection of cytomegalovirus with your pregnancy. It accounts for some pretty awful statistics. So up to 20%, miscarriage, can cause stillbirth, preterm delivery. We don't generally test for CMV with our normal pregnancy workup at this time. Babies who are carried to term, when mom had her first, her primary cytomegalovirus infection during her pregnancy, these are some of the things that it can do to baby. It can cause them to be born with a head that's too small, enlarged spleen and liver. It can cause cataracts, and this is the most common, is it can cause hearing loss, which can be rather challenging because it's not, they may pass their newborn infant hearing screen, but then later on have hearing issues that can cause cerebral palsy, intellectual disabilities. We do not have a vaccine for CMV right now, which is pretty sad. Here's some more statistics on CMV. It is the leading infectious cause of birth defects, 1 in 200 babies. Annually, 20,000 to 30,000 annually born here in the USA. More children are affected by CMV versus Down syndrome and fetal alcohol syndrome or other neural tube defects like spina bifida. 1 in 5 babies with congenital CMV will have lifelong health problems. And then 85 to 90% of newborns with CMV are asymptomatic at birth. So we don't always know that this is going to be an issue right away. Next, we're going to talk about HHV 6 and 7. These two are really, they're really similar. Let me move myself over here. There we are. So roseola, infant roseola, or 6 disease, it was considered the 6th of all the viral exanthems that children usually got back in the day with their viral childhood illnesses. It is, it stays in the lymphocytes once it's dormant, spread by saliva, and which, if you think of any daycare or preschool, lots of saliva going all over. Kids are gross, but they're adorable. Usually get a really high fever, all the normal viral symptoms, and then once the rash appears, they're no longer contagious. That usually means they're getting a lot better. HHV7, pretty much the same thing. You get a high fever and they feel sick, and once they break out in a rash, they're no longer contagious. They're on the mend. All right, so now we have the varicella, which is HHV3. So this is the virus that causes chickenpox and shingles, and then we've got Kaposi's sarcoma virus. So go in here to chickenpox. So the initial infection is called chickenpox. So it's spread by respiratory or direct contact with the open sores, and they have all the normal viral stuff. They've got a fever, a stomach ache, a headache, they're tired, and they also get these really intensely itchy pox. So they start off as just little macules, and then they progress to vesicles and pustules, and they're intensely itchy. Most children don't have complications. Some do get severe infections. Adults, it can be deadly. If your primary infection, you pick that up when you're an adult and you have no previous immunity to it, you can have an overwhelming immune response and likely end up in the hospital or worse. With a fetus, you don't want to get this while you're pregnant. Underdeveloped limbs, you can have cataracts and a lot of intellectual disabilities. So with the chickenpox virus, our body, it's a herpes virus, so we don't totally kill it. So once we have our initial infection of chickenpox and then we get over it, it's not dead. Our body just contains it. For whatever reason, our body has decided that the spine is the best place to store the varicella or the chickenpox virus. So you get chickenpox, you get over it, or you get vaccinated and your body makes immunity to it. And then it stores it on one side of your spine or the other in what we call a dorsal root ganglia, stored in the spine. Now, it's anybody's guess where it's going to be stored. It can be in the cervical area, the thoracic area, the lumbar area. It picks one side, and that's where it stores it. We can check for IgG antibodies to see if you have immunity to varicella, but it doesn't tell us where at on your spine your body has decided to store it at. So when shingles, or when the varicella virus reactivates, or when your chickenpox virus reactivates, it comes out as shingles. So whatever nerve root it was stored at, it's going to come out as a painful blistery rash. So this can be on the head, it can be to the lumbar area, it can be in the thoracic region. It kind of likes T4, that's one of its favorite places. Whichever dermatome it is, and it will always be in the same spot, because once that virus has been contained in that dorsal root ganglia, that's where it lives forever. So if you have a patient who is immunocompromised and it comes out as a blistery rash, say around T4, 10 years later, if they get shingles again, it will be on T4 on whatever side it was. Shingles is, so a person with shingles, an active case of shingles, they aren't contagious to anybody as long as the other people have been vaccinated for it, or they themselves have had chickenpox at some point in their life, because then they have their own antibodies. So shingles, now any patient with shingles, we want to counsel them not to hold any babies under 12 months who have not been vaccinated for chickenpox yet, and maybe avoid those people who are immunocompromised, because they might not have adequate IgG antibody protection to the varicella virus anymore. And our last HHV virus that we're going to talk about is the human herpes virus 8. This is the one that can cause Kaposi sarcoma cancer. It's a cancer associated with that virus. So again, some of these viruses can cause cancer. This one stays dormant in the B lymphocyte cells and the endothelial cells. It's spread by saliva and sexual contact. And so since it's stored in the epithelial cells, that's why it will come out when your immune system is down. It will come out in these purple-like patterns. We didn't see it very much in this country before the AIDS, AIDS came to its peak in the 1980s, and we started seeing a lot of cases with this. It is spread sexually and by, and by direct or sexual contact and saliva. In this country now, with our progression and our huge improvement that we have with HIV treatment and prevention, in this country we don't see it very much, but about 75% of the cases are in Africa, which, as you know, has a much higher HIV and AIDS rate, unfortunately. So, and that is all 8 of our herpes viruses. So you can go ahead and email me if you have any questions. Okay, thank you.